All right, folks, this is the CodeX Prior Authorization and Oncology session. There's a lot of slides in here that are on rinse and repeat, so forgive me if you've seen any of these slides already. My slide here says it's a demonstration that was provided to ONC, and that's a FUBAR on my part because I don't actually have the demonstration, but I'm going to talk to you about what was demonstrated to ONC in January. So first, some background. The prior authorization use case in CodeX is in cooperation with MCode. We've taken the minimum oncology data elements and included them as part of our prior authorization requirements. The attitude that we are, or the use cases we're looking for are that we collect patient data once and reuse them in multiple use cases. And this would be, for example, in the radiation therapy data elements, the CodeX, the genomics is part of this. We get genomic data as part of our data elements. And the cancer registry is another use case that's in the Da Vinci CodeX neighborhood. This slide is talking about the genomics again, whereas CodeX is the umbrella project for exchanging genomic data, as well as cardiovascular domain, and of course there's the oncology domain. So in our prior authorization use case for oncology, we've focused on prostate cancer to start with. We hope to go soon and focused in prostate cancer in the radiation therapy space specifically. We are hoping to go into medical oncology next, along with breast cancer and prostate cancer both. And just to show you the impact, we started with this proof of concept idea in 2020. For, again, I talked about breast cancer and colorectal cancer. We ended up deciding to switch into prostate cancer for 2022, 2023 timeframe. And then we had to first start with connectivity challenges and get the collaboration partners. We ended up getting Evernorth or Evercore, which is the prior auth organization behind Evernorth. Varian as our EMR participant, because Varian represents 70% of the radiation therapy market for EMRs. And then our provider partner is McKesson's US National Oncology Group. So it's a pretty good representation for a proof of concept. The accelerators, I just want to talk a little bit more about some of the accelerators in the HL7 FHIR group that we cooperate with or collaborate with. You've seen all these before, specifically with the prior authorization use case is Da Vinci, CodeX, and there's some Vulcan in here because of the clinical data research that we hope to use the same set of data to feed into. The use cases within the CodeX framework for prior authorization, the cancer registry, the radiation treatment therapy data for cancer. Again, I talked about some of this up front, so I'm not going to stay here very long. The time frame where we started. So again, the discovery and planning, and I want to make sure I'm not in front of the slide there. I'm sorry. This all came in the late fall of 2020. By February of 21, we were starting to gather our artifacts. We had provider-payer listening sessions to gather information and get concerns and understand needs. Then by the end of 21, we actually had a high-level pilot potential framed out. In the following year, we ended up doing a demo of the CRD DTR PAS separately. So those are the 3 implementation guides that go into your prior auth use case. In September of 2022, we had our first POC 1.0 stood up, and that was really basic connectivity between the 3 partners. Just showing that we can move data. We didn't have any workflow worked out by then. We did by June 2023, so we had we had a pretty good point of proof of concept where we were using synthetic data, getting test users, not clinicians, testing. I'm going to fast forward a little. So in January of this year, we actually had clinician testing. So clinicians were using their EMR, was with synthetic data though, but they were actually in their workflow testing the prior auth process. Some of the workflow that we're testing, you're probably interested in that. So I'm going to back up. I'm going to tell you what you know already, the bad stuff. Oh, I skipped the bad stuff. No, I did. Okay. The slide looked a little different. I apologize. So in the bad way, you have an appointment. You do a consult with your patient. The patient leaves. Clinician goes into the EMR, enters an order. They then ask the office staff to get a prior auth for that order. The office staff gets on a portal, hopefully, and not making a phone call or sending a fax, but we're going to say, happy path here, they're on a portal. They run into some questions they can't answer. So the payer needs more information, or they offer an alternate suggestion. The office staff is not qualified to accept the alternate suggestion. So they have to go back to the clinician, interrupt the clinician potentially in another appointment. Then they go back and forth, and the payer can't approve, and here comes the dreaded peer-to-peer. So the clinician's on the phone with the payer. They reach an agreement, and now the payer can't approve it, and the clinician has to then go follow up with the patient and re-enter the order in the EMR. So what our workflow is suggesting, rather than be tedious and inefficient and iterative, is that we shift left just a little bit. And what we do is we have the appointment with the patient, and right there in your consult, you use your Smart on FHIR Prior Auth app to contact the payer system. And the clinician launches this app, and it may happen before entering an order. Maybe it could, doesn't have to. I know there's some staging and stuff that might prevent you from being able to do this, but the payer gets data from the EMR through the Smart app, reaches right into the EMR to answer questions. We can invoke some AI or ML right here at this point. And the payer then would, through this app, in the EMR workflow, ask for any missing information. Ideally, if the EMR has all the data that M-code is asking them to have in it, we won't have to ask you any questions. And then the payable communication goes back to the clinician right there with the patient in the room. If the order select trigger was used, because there's 2 points, the order select is before you enter the order sign is when you are entering the order or submitting the order. But if the order select was the trigger point, we would hope that we could say, can I change that order to, if there was an alternate recommendation, can I change that order for you? You don't have to retype it. We're also talking about price transparency being able to be invoked right here with the patient in the room. That, of course, requires that the payer data be available. So there we go. This, the clinician might have to have a couple of extra clicks, and there might be a change in the workflow, but it seems to be what we're testing in our proof of concept or pilot program is this palatable to the clinician? Is the clinician going to accept this? So there's the expedited approval. If it avoids a peer-to-peer, if it avoids re-entering orders, if it avoids office staff having to have conversations back and forth. So we're asking our pilot participants, tell us if this is going to work. So our proof of concept 3.0, that's coming up. Well, we just had the 3.0, 3.0 was in January. And we did get some clinician feedback. Again, we used the test environment, but we did use real clinicians. We used synthetic data with data that was refreshed every 24 hours. That was a shortcoming of the Varian FHIR server vendor that they're correcting. They're changing it so that their FHIR server is updated real time. And I could explain that a little bit. When your DTR process is reaching into the EHR, it's not really reaching into the EHR directly, it's reaching into the FHIR server. So we don't have direct access through the DTR to the EMR. It's got to be through the FHIR server. So Varian's FHIR server vendor was only updating their FHIR server at night. So we wanted to make sure that data can be refreshed real time, because if I just entered something 10 minutes ago and I now am going through my clinical requirements and I had data that is not in the FHIR server, I'm not getting the benefit of not having to ask the question again. So the questionnaires were completed manually, manual entry-like, because of the FHIR server issues and possibly multiple questions. So then we conducted the user survey. We did get some feedback saying that they were excited that the data will flow into the system automatically, and they did agree that the process will lessen administrative burden. There was concern, though, because they couldn't visualize the fact that we had to have a lot of clicks, and we were asking them questions that we were telling them, trust me, you're not going to have to answer all these questions. So now we're looking to get another proof of concept where those questions are going to be pre-filled and they don't have to answer them. So that'll be coming up in a to-be-determined date. This is a pretty good summary of what we demonstrated to ONC and what we discussed after the demo. The members are building specifications to the CRD DTR PAS, otherwise known as PARDD or PARD. We're progressing towards the compliance date for CMS interoperability. We're actually trying to get ahead of it. We were progressing when we thought we were going to have to do this by 26. We don't have to do it till 27. That said, we do have to do it in 26 for Washington. So who knows? There was a CDS hook workaround. So not all the EMRs we found are CDS hook ready. And if you don't know what a CDS hook is, anyone need that explained? We're good? Okay, so the variant didn't have their CDS hooks ready, so we did a Smart on FHIR workaround. There is an entry in the guides that say this is acceptable in the what if scenario. So there's a thing that says if you want to launch your CRD to discover your requirements before you're in the order select or the order sign, if you have a button that you want to put in your EMR to say, I want to do the what if. And that's what we use. We use that process to get around the lack of CDS hooks. We also found that another reason we couldn't pre-fill answers to the clinical questions was the CQL library is not very robust yet. So we're hoping to develop some more CQL queries that will get all the data that we need. So that was some of the challenges we had. We do know that there will be widespread impact with the benefit to the patient, provider, and health plan. It will reduce overhead for everyone. It's not just the provider that will have reduced overhead. And this is where I, as a architect that represents a bunch of different payers, are trying to say you need to do this because it's going to help you as much as it's going to help the provider and the patient. So again, the challenges, I kind of already said them. There's a little bit of a lack of readiness in the EHR and the payer systems. The lack of clarity in some of the policy convergence we were up against. They did clear up the X12 278 problem. So there was an issue where, because of HIPAA, even though the provider could have had a FHIR ready package for your prior auth, and the payer might have been able to accept it, HIPAA required that it get translated to 278 in between. So with the announcement in January that they will enforce the 278 discretionarily, that helps those that are ready to not have to do that 278 translation get around that. And then the clinical and administrative data availability at the point of ordering was another challenge. That again was the real-time updates to the FHIR server, and the lack of some of the data elements that M-Code are now saying should be required in the EHR or the EMR. That's coming up with the US CDI Core Data Plus. So in May, there's a gathering happening in DC, in Bethesda, Maryland, to say EMRs, you need to also include these data elements if you're covering cancer patients. So if you're in the cancer industry and you have an EMR, you have to have these cancer-related data elements in that EMR. So that's a pledge that many of the big EMRs have agreed to, and they're meeting in Maryland to decide what that data set is. And that's part of ENCODE as well. So the next steps we have coming up, again, I talked about some of the POCs that we did along the line. The POC 4.0, where we have more CQL, where we have more real-time data in the EHR, that should be coming up hopefully in May. And then we do target to be live in the first quarter of 2025. We're working to see if we can move that up even sooner. But we have some engineers from, commercially packaged software that say, hey, I still have to do my regular releases. And we have FHIR, Evercore that says, we still have to keep the lights on. So we push them to get sooner, but they said they will commit to at least Q1 of 2025. And that looks like the end of it. So at that point, I'll just leave this up like this for now. Are there any questions? All right. Thank you all. Thank you all for your attention.